Trucara, formerly Tier Lab, is a company that I've worked with over the years. Osmolarity testing has been a fundamental daily tenet of my practice, my office protocol. My technicians for well over a decade now know to test tear osmolarity in any patient, whether it's a pre-surgical patient or a non-surgical patient with dry eyes or ocular surface related symptoms. The first thing we do is test tear osmolarity. It's very, very important to how I go about managing patients, diagnosing patients, discussing the disease with patients, and it also impacts what I do to treat the disorder. Setting pre-surgical expectations is very important for a number of reasons. The discussion pre-surgery is incredibly important. It's incredibly important to discuss with patients that there may be a visually significant ocular surface disease or dry eye disease present before doing surgery. And the reason why it's so important is if you don't mention it prior to surgery, then it is viewed as a complication if you have to discuss it afterwards, and it is blamed on the surgery. If it's a pre-existing condition, which it often is, almost, well, I don't want to say 100%, but the vast, vast majority of patients of the cataract surgical age who present for their preoperative surgical exam for, say, cataract surgery, the vast majority of those patients will have some form of ocular surface disease, dry eye disease. Often it's a multifactorial subset of ocular surface disease subtypes. And it is critically important for the doctor to have that conversation prior to surgery, explain that it's present, explain why or why not it's visually significant. If it's not visually significant prior to surgery, it could become visually significant afterwards. And again, having the conversation, discussing the impact on surgical outcomes and visual quality after surgery, refractive targets and things like that, very important. But also, there are other issues surrounding the pre-op diagnosis of ocular surface disease. It could lead to infection. It could lead to refractive misses and unhappy patients after surgery. And it can also worsen after surgery. So if it's not a big issue prior to surgery, it may worsen because of the surgery and become a much bigger issue for the patient. So these are all good reasons to have this discussion prior to surgery, to follow an office protocol. The one that we created for Ascaris, called the Ascaris preoperative algorithm, is, I think, a great one to follow because, well, I had a role in creating it. But it is a fairly easy to use algorithmic process. We designed it so that it was heavily dependent on technicians and taking a lot of the burden and the legwork off the surgeon's shoulders. It relies heavily on objective diagnostic tools like osmolarity and MMP9, two easy tests to get by the technicians, two easy tests to interpret by the surgeon, and two easy tests for patients to understand. And so a diagnostic tool like osmolarity, a linear number that is related to the severity of dry eye disease, makes sense. Just like blood pressure makes sense. The higher it is, the worse it is. Patients understand what those numbers mean, it resonates with them, and it motivates them to be compliant with whatever treatment the doctor recommends. Similarly, the osmolarity number that patients hear from me motivates them to understand their disease, but also motivates them to treat the disease. And so that's where a number and a diagnostic tool like osmolarity has a tremendous benefit to the pre-surgical patient. But quite frankly, the algorithm that we created for ASCRS is essentially the same sort of algorithm that I use in all patients. Osmolarity questionnaire, osmolarity, MMP9 are sort of the key sort of baseline set of diagnostic and symptom tools that I use to help guide the rest of my examination and the ocular surface examination, the slit lamp examination, and my discussion and treatment plan with my patients. diagnosing and discussing with patients and treating ocular surface diseases and dry eyes prior to surgery is critically important to, in essence, decrease what's perceived as a complication of the surgery. So identifying these things prior to surgery, especially when they're visually significant and can affect refractive targets, patient satisfaction, vision, and in even some scenarios, infection, it is critically important to use a protocol, a pre-surgical protocol, the ASCRIS algorithm being one, or following that either as we wrote it or adapting it for your office, perfectly fine, as long as all surgeons are addressing ocular surface disease prior to refractive surgery and cataract surgery. It's a win-win for both patients and doctors. We all know as surgeons that the preoperative exam is fairly complicated, fairly complex. There's a lot that goes into a pre-surgical examination, not only refractive testing for IOLs and laser vision correction targets and treatments, but also the ocular surface component, which, as we know, in the modern era of high patient expectations, almost promising surgical perfection, which is incredibly difficult to do for most of us. It's so important to address all of these aspects of the pre-surgical patient prior to performing surgery. The ocular surface, dry eye, cornea examination, and objective testing is also very important at detecting, in some cases, visually significant ocular surface disease. And in some cases, those visually significant ocular surface diseases are not so obvious. And so adopting some of these point-of-care diagnostic tools can alert you to something that you might have missed. Again, in the complexity of a pre-surgical exam and dealing with the surgery, the risks, benefits, alternatives, informed consent, figuring out which lens to pick in the case of cataract surgery, where to target. Are you doing monovision? Are you doing a multifocal? Do you need astigmatism correction? Looking at all the data that we collect on all of that is time consuming, and it's complex. And with all the various choices that we have today, that conversation gets longer and longer and longer with each passing year. And then to add in the ocular surface discussion and the impact that the ocular surface has on visual outcomes, and in some cases detecting visually significant ocular surface disease, and might in some cases having to delay surgery to treat it appropriately and treat it aggressively prior to surgery. These are long conversations. And so in order to kind of minimize that burden on patients and doctors, quite frankly, and the office in general, we try to streamline the approach to not only the refractive testing and the pre-surgical testing, but also the ocular surface testing. And this is where the osmolarity tests, the new ScoutPro device, which speeds up the acquisition of osmolarity testing in patients. These technician-driven tests, the technicians, are stressed by time too, and stressed to get through a busy, long day and to do all the testing that the doctors want. And so to minimize the burden on the techs and the patients and the doctors, we want tests that are quick and easy to perform, and quick and easy to interpret. And that's where the osmolarity comes in and the ScoutPro. In the age of the premium cataract surgical practice, which many of us do these days, patients have very high expectations and in some cases expect perfect outcomes. They expect to not wear glasses ever again for anything in some cases. And so identifying ocular surface disease that might have a visual impact, what we call visually significant OSD, or visually significant ocular surface disease, VSOSD for short, can affect the refractive outcome of the patient. It can affect how close we get to a plano refraction after surgery, or monovision correction where the patient can be 100% spectacle independent after surgery. And one of the quick and easy ways to detect dry eye disease and the severity of the dry eye disease is with a quick and easy point of care test like the ScoutPro TrueCara osmolarity device. With those two numbers, one number from each eye, I can look at those numbers. It takes my technician seconds to achieve the data, and it takes me seconds to analyze the data. If either of the eyes is 308 milliosmoles per liter or higher, to me, that is dry eye until proven otherwise. The higher that number is above 308, the more severe the dry eye is. Now, can there be dry eye and other subtypes of ocular surface disease concurrently? Absolutely, and in many cases, that is the case. Allergy, anterior blepharitis, floppy eyelid syndrome, sometimes subtle corneal dystrophies and things like that can also be playing a role in the visually significant ocular surface disease. But those osmolarity numbers tell me right away whether there's dry eye disease and how severe it is. If neither eye is above 308, let's say, but there is a 8 milliosmol per liter difference between the two eyes, let's say one is 275 and the other is 290. Well, neither is over 308, but to me, that is still a sign of ocular surface dysregulation or a lack of homeostasis, and a sign that there's probably at least mild dry eye disease present when the difference between the two eyes is greater than 8 milliosmoles per liter. We've been using the first iteration of the osmolarity device in our practice at Weill Cornell Medicine for many years, and it's been great, and the technicians love it. But if we can make the device more portable, make the acquisition of the tear osmolarity number quicker, well, that's a win-win for everybody. And the ScoutPro can certainly do all of those things. It's a quicker acquisition of the data. It's portable. Technicians can put it in their pocket, carry it around. They're not tied to the base station, as it were, that usually resides in the technician's examination rooms. Now it's a portable device, much quicker and easier to access the data, to collect the data in any location in the practice, and not having to be dependent on the sort of base station that the old device used.